common thing that we always told is pediatrics and kids are not small adults. Just a disclaimer, this guy is actually a small adult, but yes, so pediatrics are not small adults. They have multiple physiological and anatomical differences that distinguish them specifically, that anyone who is handling a child, especially when in an emergency care setting, needs to be cognizant of, because especially if you're not a pediatrician or if you're not commonly handling pediatric emergencies, then you may not necessarily know what the child is ailing from, but the basic principles of emergency care of ABCD, and we went through a lot of this last week, the basic principle of emergency care and approach to the pediatric patient will enable you to actually handle this a pediatric emergency quite safely, even if the last time you saw a child was 6 months ago. Okay, so most of them kind of present the same, especially when they're having an emergency. So all you need to understand is the basic ABCD, basic pathophysiology, basic anatomy, to be able to manage a child. So first thing that we all just have to accept is kids are not small adults, they're just kids, okay? So if you were to go down the normal ABCD pathway, then there are a couple of things that are specific or unique to a child that you have to be cognizant of, because this has implications in their presentation in an emergency care setting and how you manage them again in an emergency care setting. So number one, they have big heads, okay? This again becomes significant, especially when it comes to things like heat loss, head injuries, so they're more prone to more significant head injury, but also positioning because of the nature of their head, then the positioning then makes them more, because also of the large, as you can see, there's a large part of the back there, the occiput. Then when they're lying flat, then there's a tendency, because of the large occiput, for them to kind of tend to flex forward. And this then causes their airway to be potentially obstructed. So in most situations, when you're handling a child, you have to make provisions for the large occiput, but maybe putting a few folds of bed sheets or blankets behind their shoulders, just to get their back off a bit from the bed to accommodate the large occiput that they have. In terms of most kids, again, infants breathe more through the nose. They haven't really figured out how to breathe through the mouth. So when you have a nasal obstruction, when a child comes in and has loads of mucus and obstructed nasal airways, then they will tend to struggle to breathe. And so they have to breathe the mouth, but the child struggle to breathe because this is not what they're normally used to. So this, again, this becomes a significant problem, and kids will present to the emergency department with respiratory distress purely because they may have additional, beyond any effects of the infection in the lungs or anything, but they also have blocked nose. Now, in terms of the large, more flaccid tongue, this becomes significant again because when they're lying their backs and they potentially have a depressed level of consciousness, there's a tendency for them, the tongue to fall back, and this may obstruct the airway. So in such a situation, again, just a simple head to chin lift, sniffing position will allow you to open the airway. So you need to be cognizant for a child lying on their back who may have a depressed level of consciousness, then there's a higher tendency of the tongue to fall back, and that may also block the airway. So maybe position them on the side, or if you are working in a situation where the child is unconscious, then an oropharyngeal airway to support the tongue better is more indicated in this situation. In an adult, the tongue is more defined, more fixed, so may be able to bypass an OPA, but in a kid, probably if you're planning to bag the child, then an OPA is probably a good idea. Other thing about the large tongue, this becomes a challenge when you're trying to intubate the child, because then you have this huge, massive, small tongue in a small space. So be cognizant of that, and you probably need to do a bit of practicing of intubation on a mannequin before you, or in a controlled setting before you go tubing a child. But actually, intubating a child is way much easier than intubating an adult, from my experience. And also a bit more complicated, but yeah, be cognizant of the flaccid tongue. So in terms of cricoid cartilage is the narrowest part of the airway. This is just below the vocal cords, and again, this is where things will tend to be stuck. And sometimes when you're trying to put on a tube, that's where they tend to be stuck. Compared to the adult airway, which is more cone-shaped, no, not cone-shaped, more tube-shaped, and narrowest part will be the vocal cords in an adult. Epiglottis, it's big, it's floppy, it's U-shaped, and again, when it's inflamed, for example, in epiglottitis, this will tend to compromise the airway. So the child will present quickly with this obstructed airway. But also, again, during intubation, then we normally have to pick up the epiglottis compared to the adult, where we're putting the laryngoscope in the vallecula and then pretty much lifting off the tongue. In a child, you probably will pick up the epiglottis because it's just all over the place to allow you to intubate. All right, so those are the major ones in terms of your airway, and there will be potential implications as we go along in terms of identifying the difference between adults. So these are some of the things that you have to put in your mind as you approach the child in an emergency care setting. I have a big head, I have a large tongue. This child only knows how to breathe through the nose, okay, also the mouth, but mainly the nose. But the big head is a problem in terms of heat loss, in terms of positioning. So some of the things that I have to keep in mind as I plan to handle the child. So other things, again, you look at is the breathing perspective of the child. So the thing about the ribs in neonates and young kids is they're more horizontal. So adult ribs are more like that, okay? So they're more dome-shaped, so that when you breathe in, the ribs expand outwards and the diaphragm flattens, and that creates that negative pressure that allows you to breathe in. Now for the infant, then there is not much of that pressure. So much of the act of breathing is with the diaphragm. And this explains, especially when you see a child having respiratory distress, you'll see the subcostal recessions the child will have because the diaphragm is working overboard. And this becomes significant in a child, for example, who you're bagging and you have a lot of air, you're providing maybe too much pressure or bagging too fast, and a lot of air is then going more into the stomach than into the lungs, in which case then your stomach is bloating up and your diaphragm then cannot actually expand downwards. So your ventilation will not be effective purely because the diaphragm is being splitted by the stomach. So in a child who, for example, have been bagging for potentially a long period of time, you may want to put down an NG tube to decompress the stomach to prevent that splinting that's happening, to allow the diaphragm then to expand and work accordingly. Similarly, kids, again, they have twice the oxygen consumption rate that an adult has. So I don't know how to get it up there. This is increased heart rate, increased basal metabolic rate, increased respiratory rate. All these factors put together then push the child to actually having an increased oxygen consumption. Again, this becomes a significant thing because when your child starts desaturating, they go down fast. Okay, so in a normal adult, it will take a minute or two before your sats. You'll see your sats turning off between 98, then they'll come down maybe 95, 90. A child will quickly move from a sats of 99% to a sats of 40% in a flash. Well, not necessarily a flash, but in a much rapid time frame because of that increased consumption of oxygen. So be careful when a child starts maybe not breathing or not breathing adequately, not saturating well. If the respiratory efforts get further compromised, they will desaturate rapidly. So pre-oxygenate appropriately, be ready to intervene as soon as possible because you don't have the lag time you get when you're having an adult breathing. If you look at, again, as I said, kids breathe faster, hearts beat faster, and I'll explain that and discuss the circulation part of it. In terms of blood pressure, again, we're looking at mainly the systolic blood pressure is what we kind of look at to see, and because the blood pressure really also varies as the child ages, but first month of a life, systolic less than 60, we worry it's hypotensive. First year of life, systolic less than 70, something to worry about. That means hypotension. Above from the first 10 years, first month, first year, and then first 10 years, it's 70 millimeters plus twice the age to get the lower limit of the systolic blood pressure. Again, these are good figures, and you don't really need to cram around which numbers is which. It's good for you to know where the systolic blood pressure is, but as I discuss this further, you realize this is a good guide, but I think more importantly is your clinical assessment of the child. So again, some of this becomes in handy. So you can see because of the faster heart rate in the 2020 AHA guidelines for resuscitation, they increased the rest rate to aiming for a rate of 20 to 30 breaths per minute, but previously we used to say 1 breath every 6. Now it's more of 1 breath every 3 seconds to achieve your rest rate of at least 20 breaths per minute. So that's what you're kind of aiming for in terms of your rescue breathing for the child. Do not bag too much, which I was just talking about, because you don't want most of this air ending up in the stomach, because then that compromises your ventilation. And then we are now into cuffed tubes, really. I think we're trending away from uncuffed tubes. And then again, critical pressure, that kind of went out of fashion many years ago. But in a child, again, really worried because the child's cartilages are quite not fully formed, so quite collapsible, and you may actually close off the airway in your attempt to actually put critical pressure on the child. So this is something, again, so these are quick things in your airway management that you kind of want to look out for when you're handling a child. So in terms of circulation, so we've done airway, we've done breathing, now we're actually at circulation. So in terms of circulation, again, kids have a higher heart rate. A lot of this is because they have limited ability to increase their stroke volume. So most of the BP is managed by their heart rate. So when a child's starting to become hypotensive, their heart rate is the first thing that will quickly pick up. And so tachycardia is the first sign of shock. Their vascular resistance is low. They have a lower vascular resistance than your average adult. Okay, so they've not been eating all the fancy stuff we've been eating that gives us stiff vessels that lead to hypertension. So they normally will have lower blood pressures. And essentially, actually, in kids mainly, when you're presenting with sepsis, for example, sometimes they will present with very vasoconstricted vessels and quite cold and clammy. But on average, the vascular resistance is quite low and have a lower BP, which you have to worry about. So in a patient who is shocked, then you have to think about, do you need to beyond fluid resuscitations, do I need to support the vascular resistance? Urine output, again, target is normally 1 ml per kg, but they have a higher urine output, 1 ml per kg per hour, and could go up to 2 ml per kg per hour. Something you have to worry about, and again, kids less than 5, kids less than 30 kgs, then you want, beyond your fluid resuscitations, you always want to keep them on some maintenance fluid, and whichever formula works for you. I use the 4-to-1 rule. So there is a fluid you're giving for resuscitation, there's a fluid you're using to bring up the child's BP and things like that. But in the back of your mind, there's that part, and then there's maintenance fluids. So maintenance fluids normally, again, it's something with dextrose in it, especially in kids under 5 and, as I said, under 30 kgs. So calculate your maintenance fluid. This is usually per hour. And then per hour over 24 hours, per hour, yeah, and over 24 hours. So calculate that and make sure that is running in your child, even as you work on your resuscitation on this other end. Always have the maintenance fluid at the back of your mind. So as I mentioned, the issue about the blood pressure, as you can see in this nice diagram here, is the child's cardiac output, okay? As at the bottom line there, so the x-axis, as the blood volume starts dropping, as you can see, so the blood pressure is that line there where you're seeing the x. The blood pressure does not really significantly drop until you're close to around 40% of your cardiac output being lost. As you can see, the more volume, okay, so simply put is, so this is how much fluid volume. So your cardiac output is dropping, either you're bleeding, you're hypovolemic for whatever reason, so your cardiac output is on the way down. Your blood pressure, it holds quite well. As you can see, it's holding quite well, all right? And what's making it hold appropriately is you're increasing your vascular resistance. So your child is becoming colder, having more colder peripheries, getting more clammier. But then it gets to a point then, which is, as you can see, how much cardiac output you're almost at 40%. So you lost quite a significant amount of blood or volume, and it's at this point then your blood pressure starts coming down. So as I mentioned, the key thing is vital signs are good as a guide, but in terms of reliability, in terms of how sick your patient is, especially in the pediatric population, your clinical acumen, your touch, your feel, your assessment of the child supersedes any amount of BP measuring. Besides, half the time we're using the wrong cuffs, we're using adult equipment on pediatrics. So be careful about relying heavily on your vital signs and more work on your clinical assessment of your child. As I said, in terms of disability, kids have a bigger head, so they're more prone to more serious head injuries. The bigger head allows for them to lose heat a lot through their head, because half the child, well, not half, but a large proportion of the cardiac output is headed off to the head. So heat loss from the head is quite big. So again, when you're looking at a child, then you have to consider that as an issue. And then because of the increased metabolism, they're more prone to hypoglycemia. So in your assessment of disability, you're looking at your GCS, your pupils, and you're checking your sugar, because kids will end up in hypoglycemia. And we'll discuss how we manage some of this as we go along. In terms of exposure, as you get cold, so large, the surface area body weight ratio for a kid is much larger than we have for adults. That means they get a heat loss, and of course, their skin and thermoregulatory mechanisms are not fully developed. That's why a child needs to be kept nice and warm. We normally will have the heaters, and other warming devices as you manage and resuscitate kids. So do not forget about that. Is not live. Normally you'll have your adult just hang out there, fully exposed, and may not be such a bad thing, even they should be covered. But for your child, that's gonna be detrimental, and because you're pumping in cold fluids and cold air, then that may make their blood temperatures lower. So be very careful and make sure you're covering them up and providing them with heat. So at the end of the day, again, so let's now look at, so that's a basic overview of considerations when you're managing a child. So again, quick things that you have to always have at the back of your mind in any emergency situation where a child is involved. What's their A? What are their differences? What's their B? Breathing, what are their differences? What are the circulatory issues? So when like adults, I'll be like, oh yeah, what's their MAP? What's their mean arterial pressure? In a child, I'll be like, how are they clinically? Are they warm? Are they cold? Are they mottled? How are they looking like? And so this is where your assessment as a clinician becomes very important, and your relationship with your patient becomes a bit more intimate, because you have to see, feel, inspection, palpation, the full thing that we normally used to do for patients. So there's this fancy, nice pediatric assessment triangle. I love this one because it's a good guide to assess any child coming through in an emergency situation. And if you follow the principles of the pediatric assessment triangle, then you will pick up where the problem is in a bulk of the time. It's an airway problem, it's a breathing problem, it's a circulation problem. So the first part of it is called tickles, actually. That's a mnemonic, TICLS. So what's a tone? Tone is how active and vigorous the child is, how interactive are they with the environment, with their caregiver, with you as a doctor. Are they consolable? Are they crying continuously? How are they look? Are they looking at you, or are they off in their own world? And are they crying? Are they talking? So essentially is, how is the child? And this is again in comparison to what they normally are, okay, what would be expected for their age. So that's the appearance of the child in terms of their physical activity, their mentation, and the interaction with the environment, the caregiver, and everyone. So a nice, happy, aggressive child, it's a good thing. So from the appearance, the next thing we want to look at is your work of breathing. And so note, in an adult, we talk about respiratory, it's work of breathing, okay? How much work is it checking this child to breathe? So what you're looking for, again, is any abnormal sounds, abnormal positioning, head bopping, they're breathing too much, retractions, subcostal, intercostal, suprasternal. We'll show some of this. Are they gasping? Is there nasal flaring? Okay. This again, so what is their work of breathing? Note, I'm not asking what's their BP, what's their rate, what's their work of breathing?
With upper airway obstruction, you'll typically see suprasternal retractions, or potentially sternal retractions as well in a young infant with a compliant sternum. And there's a characteristic noise that may accompany this called stridor. And stridor is a high-pitched noise that occurs on inspiration and is the noise essentially of the turbulent airflow that the infant is generating by drawing air in through a narrowed area. If the infant has obstruction at a higher level, for instance, swelling of the tongue or excessive secretions or poor muscle tone resulting in hypopharyngeal obstruction, the sounds that may be produced are much coarser. Sounds that are called stertor, for instance, which sounds more like a snoring or a rattling type of respiration. This can be easily distinguished from stridor if the baby responds to a jaw thrust maneuver, where when you relieve the upper airway obstruction from soft tissue, the noise improves. Subglottic edema won't have that same characteristic and needs other forms of treatment. Lower airway obstruction is characterized by wheezing, which can sometimes be heard without a stethoscope, but is more characteristically heard on auscultation. And with lower airway obstruction, you have delayed emptying of lung units, typically from high resistance in the lower airways, which may be caused by infection, bronchospasm, reaction to an allergen or some other type of hypersensitivity reaction that leads to narrowing of the airways that are inside the chest as opposed to outside the chest. These infants also have a forced expiratory phase and may demonstrate seesaw type of respirations. And characteristically, when you listen, you will hear a prolonged expiratory phase where there may still be sounds of wheezing and exhalation almost up until the time the baby takes another breath. Now, pneumothorax may lead to asymmetry of the chest rise and asymmetric breath sounds. One of the reasons it's important to auscultate laterally on an infant is that there can be transmission of breath sounds if one only listens apically. To hear true asymmetry, you want to get as lateral as you can. You may also observe differential chest rise.
All right. Okay, so as you can see, the discussion around that whole process was, what's the work of breathing? So the effort, how much effort, and all of this again, so if it's wheezing, there's a whole panel of issues that could be causing the wheezing, from your asthmas, your bronchiolitis, and that whole range of restrictive lung diseases. And if it's your stridor, then you know your problem is actually probably from an upper airway problem. So your epiglottitis, so that would give you a whole new sound altogether. Airway obstruction from a foreign body, croup would give you an upper airway stridor. So again, so examine your child. What is their work of breathing? And all the things I've been saying. So you're able to see nasal flaring, gasping, retractions, as had then abnormal breath sounds. So the third part of your assessment is your circulation. And this is where you're looking at, is the child pale? Are there mottling of the skin, cyanosis, absent or weak pulses? Abnormal blood pressure, again, this is just systolic. So is it less than 60, less than 70, less than 70 plus age? Twice the age, or are there any obvious signs of bleeding? And then, as you can see, it's a continuum. So you keep reassessing the appearance, work of breathing, circulation, go back. So as you identify items in each of these phases, you fix them as you move along, and you keep reassessing your child, just going around the same triangle and the same components of the triangle. So they say this is good, okay? So it's good to know maybe the respiration is a bit higher, the heart rate will be a bit higher, well, the lower limits of systolic blood pressure, but a lot of this may be unreliable if you do not have the right devices, or you're not, again, seeing too many kids in your emergency department. So then, of course, as I say, the main thing is you are the key thing. So doing a proper pediatric assessment triangle, reviewing the appearance, work of breathing, circulation, and engaging your child and examining your child will give you all the information you need to be able to quickly identify the potential primary problem and then initiate therapies based on that. Okay, so that is just an overview, as I said, from the physiology perspective to how you quickly approach a child having an emergency. And then now what we're gonna go through is probably a couple of emergencies that may show up in the AD and some of the cool things you can do about them. But again, it's not supposed to be comprehensive, but that general approach gives you an idea of where to start from to prevent you running like a headless chicken sometimes, especially if you're really panicked. So I hope that helps with that part of it. So for me, anytime, again, so wet flag is a mnemonic that is very useful when you're approaching a child who needs to be resuscitated, okay? So W stands for weight, and there are formulas to this. So twice the age plus 8, this is for your 1 to 10 years of age child. In terms of, so the first thing I'll probably say, I come across a child, how old is this child? Oh, it's 5 years. All right, so what's my wet flag? Okay, so quickly figure out what's my weight. And so if it's nice if you have a nice Broslow tape, which I'm sure most of us don't have. So the formulas do help with the approximation of the weight. And then from that, then everything else in a child is per kg. So That's a figuring out what potentially it's nice. Or another way you could actually just ask the mother how heavy is the child. That also kind of helps. But then if the mom is not there or someone doesn't actually know the weight, then you can actually approximate it using one of those weight-based formulas. And then energy is how much in case you need to defibrillate this child, then which is quite rare, but it could happen. How much energy will I be using? That's 4 joules per kg. Now, if I need to tube the child, okay, so what size of tube am I using? So again, if I'm using a cuff tube, that is age over 4 plus, I think it's 3.5 if I'm using a cuff tube, 4 if I'm using a cuff tube. And then how deep is this tube gonna go? Again, tube, 3 times the size of the tube, that tells me how deep the tube should be. The other formulas, so the thing is, there are multiple of them. So you have your, know which one works and which one has been potentially validated. And then just know this and have this so that as a child rolls into your AD, quickly do a wet flag so you know where you're starting from. So your fluids is, I always do 10 mLs per kg. We used to give 20 mLs per kg, but over time, smaller boluses are being recommended for many, there's so many contraindications to 20 mLs per kg. There's just either just at 10 mLs per kg and just keep reassessing and repeating it as required. We don't have much lorazepam on our side, so we normally end up using midazolam. So in this situation, my flag is FMAG, okay? But yes, so midazolam is my sedative, 0.1 milligrams per kg. And then if this child's gonna need resuscitation, then I need to give adrenaline. And adrenaline, I give 0.1 mLs per kg. Now, of 1 in 10,000. I just need to emphasize the 1 in 10,000 is when you take a 1 milligram of adrenaline, which is a normally small vial, and take a 10 cc syringe. So you take your 1 ml of the small vial of adrenaline, top it up to 10 mLs, so that it gives you 1 in 10,000. Now 0.1 mLs per kg of that, okay? And you can use your smaller syringes to draw from that, but that's a 1 in 10,000 solution, all right? And so it's 0.1 mLs per kg of the 1 in 10,000 solution. Glucose, again, 2 mLs per kg of 10% dextrose. You can repeat it if there's no improvement. Yes, so again, even dextrose, we are kind of moving to not using 50% for sure, but again, just 2 mLs per kg. If it's no improvement, repeat it, and you can go all the way up into 5 mLs per kg. So my wet flag is like my what can I say, my go-to, okay? So my child has come in, what's my weight? And then what's my red flag, so that when I start resuscitating the child, then this information is readily available for me as I need to resuscitate the child. So it's always a good idea if you have a pediatric resuscitation area to have a whiteboard of some sort, so that someone can quickly write what the red flag is for that child. And then you can then quickly know what you need to do with. There are bigger charts with more information that you can actually print out. I think we have some in our protocols that we share along. And it's also a good idea to just have this, especially in a pediatric emergency department, have this up on your wall. No one remembers these things in a resuscitation, and it's always good to have a reference point and say, what size tube do I need? Oh, my child is 10 kgs, that's what I need. And similar kind of, because in a resuscitation, everything's a bit fast. A guide on the wall really helps. What's my red flag? So now let's look at some patients who present, and we'll just go down the usual A, B, C, D kind of presentation. So this is an airway patient.
All right, so we're doing a video on croup, and this will help people in the community out there to understand exactly what croup looks like. This young lady actually has a fairly impressive croupy cough, and this kind of this seal-like barky cough and some stridor. And Mom's willing to list this video to teach other people what it sounds like. She's already had some racemic epinephrine, and I think she got steroids at the outside hospital before she was transferred into the children's hospital. So listen to that. So the typical treatment for croup is basically a steroid, and usually use 0.6 milligrams per kilogram of Decadron, dexamethasone, and then also racemic epinephrine. A lot of these children can actually go home, but she's unfortunately, I think, going to get admitted. Do you agree?
Agreed.
Yeah. But yeah, a lot of times the steroid works really fast. But listen to that.
You trying to cough?
It's probably been an hour since she got her semi-geppy. And she's sleeping quietly, but she's got that inspiratory strider type sound.
Okay, so that's the child having a croup attack, and essentially self-limiting a lot of it, and child will probably grow out of it. So it's mild. Again, everyone gets steroids, as mentioned. So your dexamethasone 0.6 milligrams per kg orally or parenterally as a single dose is the treatment for this, for all of them. So make sure you get your steroids into the child as soon as possible. And then if you're having, so as you can see, mild is just occasional barking cough without audible stridor at rest. Moderate is frequent barking cough, audible stridor, and visible respiratory retractions. Remember the retractions I mentioned, subclass on the rest. Then severe is where you have frequent barking cough, marked stridor, visible respiratory retractions at rest, child's agitation and distress, like the child that we had. So yes, so again, the first thing they get is the steroids, orally or parenterally. In a severe one, probably end up with parenteral because they may not be able to be in a position to swallow. And then you have your nebulized adrenaline. So racemic epinephrine is a special type of epinephrine. We normally end up just using one normal epinephrine. So racemic epinephrine is one that is easier to nebulize. I think that's the main thing, but it's just adrenaline. Okay, so either racemic adrenaline or adrenaline. And again, this is nebulized, and if the child needs oxygen, then they need to get oxygen. So that's for your management of your croup patient. Normally, we present quite dramatically, but they do quite well, and all of them will end up actually going home. Swallowed foreign bodies. So anything goes into the mouth, okay? So what are the things we really panic about, okay? If they're sharp and if they're long, more than 5 centimeters, panic about that. There are some rare earth magnets. I've never seen those ones, but or if your child has swallowed 2 magnets, because sometimes what happens when you swallow 2 magnets, and they could easily go into the abdomen and just attach each other at different points, and that could be a problem. So worry about those ones. Baton battery is what you get inside your watch. So those batteries that are normally put in watches, remote controls for like your car or something. So the baton batteries are the worst kind of thing that you really want your child to have swallowed. And so if you have a baton battery in your esophagus, or if your child has it in the stomach and they're symptomatic, then these need emergency removal, and GI specialists will need to be involved in this, pediatric GI specialist. And of course, anything that has been, if it's producing any symptoms of obstruction, of course, then it needs to be removed, or it's been stuck in the esophagus for the last day or so, then that needs to be removed. Everything else kind of tends to pass down on its own, okay? So we'll kind of go down the GI tract, so you don't necessarily have to worry about most of the things that kids swallow. But as I say, the one thing that you really want to worry about is this baton battery. So, and it's very important as a healthcare provider working in the emergency department to distinguish between a coin and a baton battery, because a coin is fine. A coin stuck in the throat, if it's gonna get down within 24 hours into the stomach, that's fine, nothing to worry about. The child will be richer when they go to the toilet much later. But if it's not a coin and it's a baton battery, that on its own is an emergency, and the child needs to be taken in for removal, scoop removal as soon as possible. So how do you distinguish between the two? I think the trick to it is the baton battery gives you a double lucency. As you can see, there's that lighter part on the outer, like a rim, and then there's the inner part, which is more darker. And on the lateral view, because you always have to do an AP on the lateral. So on the lateral view, again, you can see the 2 lines, okay? That is very much indicative of a baton battery. And just using this example, as you can see, that's a baton battery, that's a coin. Okay, a coin doesn't have that double lucency thing that you're seeing over there. This is a baton battery, this is a coin. This is an emergency, this is an emergency only if it's causing any obstructive features or it stays in the child's throat for more than 24 hours. Then we may need to worry about it. But otherwise, a coin in the throat that's going down, yeah, it's fine. It's going to get wherever it's going to eventually. All right. So in terms of button batteries, things again. So if your patient is asymptomatic, figure out where it is. If it's in the esophagus, it's an emergency. If it's gone down there, if the patient remains asymptomatic, if it's gone down the esophagus and it's a small battery, fine, the patient can potentially go home, but we'll need some follow-up on this one, okay? And come back when child experiences any symptoms. So this is quite a child who must be very easy to follow up. So it's not a child who's gonna be going to another county to stay there or to a village somewhere. So it's a child who will come back and clearly understands what when they need to come back. If you're not sure, admit them and then observe them in the hospital. But if you have a good if your parents understand and there's good emergency response systems in some areas across the country, then it's good. They can go up and then follow up in a clinic. But if your patient is symptomatic, then of course they need to be resuscitated, of course your ABCs. And again, most of the things, the one thing you're worried about is it's causing bleeding in the tummy. And this again, you need and could cause significant amount of bleeding, especially if it's eroded through areas where there's a vessel, because the battery essentially, because of the electric capacity, the electric electrons, I guess, on the battery, it does erode through your gut. And this could easily go into a vessel and cause significant bleeding. This one is to go into surgery ASAP and have it removed, extra-visual where it is. In your ear, nose, if possible, remove it, okay? And we go through some of the things stuck in the nose and see how we remove those ones. But if not, if you're not able to remove it, send to a specialist for them to remove it. And again, worry about having a clear safety net where when to come back to the hospital if there are any symptoms, and the child definitely needs to come back as an emergency. Okay, as I said, if there's no high-grade obstruction or no acute distress, fine, wait for it. Okay, it will go down, and if it's going down, it will go down and poop. Do not leave anything in the esophagus for more than 24 hours. If it's stuck in the esophagus and there are no symptoms, again, child can take some water, eat some bread, and see if that pushes it into the stomach, because from the stomach, then things will be fine. Will be followed up. Okay, and please don't tell the mother to keep checking the poop. Okay, a lot of these things are not found. So this fishing of things in the toilet is really not recommended. So it's not, yeah, unless it's something really valuable, then in that case, yeah, you probably want a diaper and keep checking through the poop. All right, but it's not really recommended that you have the mother keep checking the poop. All right, so swallowed foreign bodies. Okay, I'm going to show you a video about what we call, essentially it's bouginage. Bouginage is a trick you can do in an emergency department to remove a foreign body that a child has swallowed that's still stuck in the throat and is potentially needs to come out. And it's been there maybe for a couple of hours and it doesn't seem to be moving. They've eaten a few pieces of bread, it's not moving. Then you can consider pulling it out. But do not do this. Number one, of course, you must have understood the procedure. Potentially, you should be able to have some senior consults as you do this. Do not do this if your child is in respiratory distress. Do not do this if it's something hazardous. As I mentioned, your magnets, button batteries, complex shapes, and sharp objects. If the child has more than one coin in the throat, if it's been there for more than 24 hours, or you do not know how long it's been there. Children with esophageal injuries, abnormalities, prior surgeries, do not attempt this. And of course, child with a history of prior esophageal foreign bodies, again, this should not be attempted. So that's just a Foley's catheter being put in down as an NG tube. In this case, actually, so it's an oral tube. Yes, the child is being encouraged to swallow the Foley's catheter. Yes, the Foley's catheter is being inflated. Okay. The child leaning forward and the clapping. And voila, there comes out the coin.
Esto no se come, mira, esto no se come. Cuando veas esta, ya no te la tienes.
So it's a fairly safe procedure. A lot of studies have actually been done looking at its safety, and it's actually fairly safe. Don't need to sedate the child, just have a child swallow the Foley's catheter, inflate the catheter, and then have it done. But as I mentioned, the things to worry about is do not do that in this kind of situation, which I've gone through before. Size of Foley. So you can check the link below, you take a screenshot, take a snapshot of it. You can go read about it if you're interested. And yeah, so read, understand the procedure. And again, if you're doing it for the first time, then you probably need a senior consult with you, but it works very well. So usually what's used is a Foley's catheter in our setting, but as you can see, you can use an 80 tube, has dilator, but a Foley's is more readily available. And they're very good notes and discussions on the link on how this can be done and how to prepare for it. So before you do it, please make sure you know what you're doing. All right, let's go into the nose. So yeah, so what happens if something goes through the nose? I have seen healthcare providers struggle get things out of the nose, like pretty much short of beating up the child to get the thing and poking everything out of the nose, poking things into the nose, then it's horrendous what people do. But removing something from the nose is the easiest thing in a child. From my experience, works easily. And so I'm going to show you a sample of techniques that you can easily remove even at home. I've had my neighbor, I've removed one from my neighbor, they brought a child here with something stuck in the nose. So a couple of techniques that are easy, quick, safe, and do not need the child to be assaulted in the process.
Blow your nose real hard.
As hard as you can. You're doing a good job.
Okay, Julie.
One more. Oh, that's
there
it.
you go.
Done. Finish.
Now you can open your mouth.
Mm-hmm.
You okay?
Bailey, you open your mouth, baby.
All right, turn your head this way.
Open your mouth, baby.
Straight.
Yeah.
Straight as you can. Good job.
1, 2, 3.
Lock that ear.
Oh, it's working.
Oh,
We're working.
it's okay. It's coming, baby. Hold on. I'm trying to get that beat down.
Keep your mouth open.
Keep your mouth open. It's making funny noises. You hear it? Isn't that silly?
Yeah.
Good job.
All right. So you can do, if you can ask the mom to do the mother's kiss, unless you really want to be kissing that baby. So the main thing behind the mother's kiss and the use of the ambo bag is the nostril that is open, is blocked off, and the child's mouth is left open, and the gush of air is blown through the child's mouth. So the mouth and your nose are connected. So the air essentially goes up the mouth, into the hypopharynx, then out through and pushes out whatever object is there. Okay, if you're not comfortable doing this, another easy trick of it is connect. If you have air blowing off your wall, then what you can do is just take a big, nice, thick tube. Your suction tube works. Connect it not on suction, but on the air or the oxygen. Turn it maximum. The tube normally is big enough to fit into the child's nostril, the normal nostril, the one without the obstructed. Then have the child's mouth closed, and then just turn up the oxygen. That stuff falls out straight off. Or if you are feeling nice, you can blow the other end of the tube versus using oxygen, and it comes out. No assault needed, nothing, and it works very well in the ED. All right, what about shock? Okay. So again, any child who comes in sick, the first thing you really want to worry about is this child septic? Is the child having anything suggestive of sepsis? So sepsis, essentially you have an infection that your body has gone crazy trying to fight and all your systems are getting affected. That's the easier way of putting it. All right, so things to look out for is fast breathing or long pauses in breathing, okay? Okay, so worry about that. Blood skin or pale skin, again, floppy child, rashes that do not blanch when you use a glass test. This is when you're worried about meningococcal infections. Child who is drowsy, difficult to wake up or confused, feel abnormally cold to touch. Child who presents with a fit or having convulsions, or a lot of pain and very restless. So all of this could easily be sepsis. And you need to worry about sepsis in that child where you're actually not telling what's going on, or you actually can identify there's a source of infection, but then has a systemic involvement of the infection. So the key thing about sepsis, again, is first thing and most important actually to think about sepsis, okay? Then look at all the parameters in the child and figure out, are they having sepsis? If they're having sepsis, then the key thing is you want to fluid resuscitate. If they are hypotensive, you want to make sure you culture your everything that needs to be cultured. And then, of course, you need to start off with your broad spectrum antibiotics as soon as possible. The main other things that needs to be done in terms of your fluid resuscitation. So especially in terms of fluids, again, if your child has abnormal perfusion, so they're cold, clammy, and without hypotension, most of the time it's 10 mLs per kg of what we're doing of the fluids. And again, your Ringer's lactate is probably what I'll use most of my situations. So 10 mLs per kg, you give, you reassess. If they're still poorly perfused, you give some more, okay? 10 mLs per kg and reassess. So at every point, you have to reassess your child. So do not rush and give large boluses of fluid. And again, if you've given 2-3 boluses and your child is not getting better, start your inotropes, okay? So your adrenaline, noradrenaline, because then the child may require a bit of help with the vascular resistance and cause vasoconstriction. Kids who end up on steroids, again, on inotropes, then of course we need to also consider giving them steroids. But the main thing is early identification of sepsis. So early identification of sepsis, fluid resuscitation, initiate your antibiotics preferably after you've done your cultures, but again, do not delay antibiotics trying to figure out where the cultures are coming from, but get your cultures. The lab people are very annoyed when you send cultures after you've given antibiotics. And then again, if after 2-3 boluses, your child is not getting better, consider starting your inotropic support or vasopressors, and then of course, again, give steroids to this group of patients. Again, in any fluids, again, also consider your maintenance fluid. I say you resuscitate, but there's also the maintenance that needs to be done. All right, let's look at the neurological effects or neurological presentations for these kids. Key thing again, child who presents with seizures, benzo, okay? Benzo 1, benzo 2, all right? And again, wait between your benzodiazepines before pushing in your anticonvulsants, okay? And by this again, you need to, at least the first thing is at least 2 doses of benzo, then give your phenobarb, 20 milligrams per kg, then 10, and then you probably need to be getting specialists at this point if your child is still convulsing, because intubation and ventilation and paralysis may be required. But the thing about midazolam is you can see everything buccal, okay? So for years, we've done things, we've given drugs up the bum. But again, there's good evidence that there are better ways of giving drugs than up the bum. So the issues of social stigma, I'm not sure that's very common in our setting. But the other thing to worry about is if they have a shorter duration of action, the child, due to the convulsion, could easily pass poop and pass out your drug, so that's not going to work. And then there's, of course, a good trials and randomized control trial that shows buccal route is more effective than the rectal route. And this.
How do I give buccal midazolam? Buccal midazolam is a medicine that is used for seizures that do not stop on their own. Your child's care team will give you specific instructions on when to give buccal midazolam. If your child has a seizure, make sure your child is safe. They should be lying on their side with nothing near their head that could cause injury. Remove the child's glasses and loosen anything they may have around their neck. Do not put anything in their mouth or try to restrain them in any way. Start timing the seizure. If the seizure continues past 2 minutes, start getting the buccal midazolam ready to give. You will need a 3 ml syringe with vial access cannula and the medicine vial of midazolam. Remove the cap from the syringe and the cap from the medicine vial and set aside. Draw up air into the syringe by pulling back the plunger to the 2 ml mark. Pierce the medicine vial with the vial access cannula. Push the air into the medicine vial. Draw up the amount of medicine your child was prescribed. Remove the vial access cannula and syringe from the medicine vial. The blue dart will remain in the vial. Put the cap back on. Twist the vial access cannula to remove it from the syringe. Set it aside. Use your free hand to hold the top of your child's head to keep it from moving. Place the syringe inside your child's mouth between their lower gum and cheek. Slowly compress the syringe plunger to trickle the medicine into your child's mouth. Your child should not swallow the medicine.
All right. So this is one that where it's an educational video for someone giving it at home. Nothing stops from giving it in the emergency department. Okay. So sometimes the child may be thrashing around, and IV access may be a bit of a challenge in that part maybe more harmful actually to the child and to you if the child is not controlled. But so buccal midazolam works as well. Okay. Same dosage. Okay. 0.1 milligrams per kg. Actually, for buccal, you probably want to go 0.2 milligrams per kg in the buccal cavity works as well. Okay, so less bum sticking, more buccal cavity fitting. Yes. So benzo, midas, 0.2 milligrams, you're going buccal, and then again get an IV access IU in case you need to give you a second dose. Okay, but so buccal, not bum, phenobub, call for help. Get your emergency center, prepare to intubate at this point. Then again, you may give a third dose of phenobub. So 2010, 10 accordingly. Don't ever forget glucose. So ABCDEFG, don't ever forget glucose as a cause of seizure. So a lot of it, as I said, hypoglycemia, increased metabolic rate in kids, hypoglycemia is common. So all children just check their sugar. If they're sick, check their sugar. Okay, and 2 milligrams per kg, 2 mLs per kg of 10% dextrose, and you can repeat up to 5 mLs per kg. And this is a neat trick to do because you may not have 10%, maybe you have 50% dextrose available, but you don't have the 10%. So you can take up your 50% dextrose. So if you want to make 10% dextrose, then just take 10 mLs of the 50% and then make it up to 50 mLs. If you want to take 25% dextrose, then you take your 50% dextrose, take 25 mLs of it, top it up to 50 to get your 25%. So it's a nice way where you don't have a variety of dextrose solutions and you need to quickly make up dextrose from your 50% dextrose solution. All right, so 2 mLs per kg, 10% dextrose solution. Seizures, again, so febrile seizures, quite common, and there are a couple of things you just need to be able to identify. What is a febrile seizure? What is a seizure we're worrying about, okay? So if it's simple, so the key thing is it's a childhood seizure after 1 month of age. You know, they say 6 months to 5 years or 6 years, depends, or 5 years actually. Child has a febrile illness. So there are no features of CNS infection, no previous neonatal or unprovoked seizures, doesn't meet criteria for other acute symptomatic seizures. So if it's a simple seizure, we are good, okay? It's a febrile seizure. If it's not, that needs to be investigated, okay? So a simple seizure is less than 50 minutes, it's generalized, no recurrence within 24 hours, and again, no post-ictal pathology. So there's no weakness, there's nothing. Things to worry about that it's potentially a CNS infection is if your child was on antibiotics, if it's complex, if there's history of irritability, decreased feeding, and lethargy prior to presentation, Okay, child is not fully immunized. Again, child has post-ictal symptoms that last more than an hour, then we are not talking about a simple seizure. Things like limited social response, altered consciousness, neurological deficit, drowsiness. These are things you really worry about. Of course, there's some signs of neurological infection in terms of meningitis. Again, worry about this, okay? So bulging fontanelle, focal neurological signs, neck stiffness, photophobia. But again, symptoms and signs of agitation may be absent in children under 2 years. But the key thing is check so that it's either a simple seizure or a complex one. If it's simple, then that's simple. Simple seizure is easy. No routine investigations. Check urine if you can't find an obvious focal infection. So tepid sponging is no longer recommended because this triggers the child to generate more heat to try and keep up with your cooling them. So no tepid sponging, no overdressing, no underdressing. So yeah, this thing of running kids around, just normal dressing, okay? Your Panadols, your antipyretics, they make the child comfortable but do not actually prevent the recurrence of febrile seizures. So don't tell the mother this will stop the seizures from happening. That's a lie. Okay, they will make the child more comfortable, but they will not prevent the seizures. So again, those things to work out, it's a childhood seizure after 1 month of age, child has a febrile illness, no CNS features, less than 15 minutes, generalized, no recurrence within the last 24 hours, and then no post-ictal pathology as discussed. All right, C-spine injuries are not that common in kids, but worry if a child has axial loading, means they fell on their head, they are confused, there are features of basal skull fractures, they're in respiratory distress, they're in decreased oxygen saturation, substantial injury to the torso, substantial injury to the chest, okay? If you do not have any of this, then chances of you having a C-spine injury are very minimal. You probably can bypass the unnecessary imaging to the thyroid. But if you're gonna do a C-spine X-ray, then you have to be able to interpret. Remember, there's a lot of bone still information. So this is a very good way to quickly pick up where the problem is. Of course, if the bones have moved, then you need to worry. But if there's no obvious bone movement, the other thing you really want to check for is the soft tissue. This is what we call the Swiss chart line. So it's a soft tissue line anterior, okay? As you can see there, so it's anterior to the vertebrae. So that soft tissue line ideally should be less than 7 millimeters at C2, okay? So that's around C2, and less than 22 millimeters, okay, at the level of C7, okay? Normally we'd say the width of the vertebra, okay, at C7 and less than 7 millimeters at the width. So if you see widening of that space, essentially that translates to is bleeding from somewhere, and this probably, the spinal columns may look intact, but there has been bleeding, means there's been movement and injury. So that is an indication of spinal injury and may need to further imaging, probably CT neck or, yeah, probably a CT neck in a trauma situation. So that is a very important line to keep track of. So ideally, not more than 2 centimeters there or 22 millimeters there. And then not more than 7 millimeters. So as you can see, this is C1, C2, C3, C4, C5. It starts translating into that, C6 and C7. So from C5 to C7, and there's your T1, that should not be markedly enlarged, similarly to the top there. There's issues of subluxation that you need to worry about. This is the posterior spinous processes, the anterior. So this is normal, okay? So sometimes you'll see the C2 anterior aspect of the posterior arc is deviated less than 2 millimeters, that's fine. But you can see this has moved a bit. If this is more than 2 millimeters, then you worry about subluxation of C2, which is quite common again in pediatric C-spine injuries. All right, when to CT, when not to CT, okay? So this is in a child, this is head injury child who has mild head injury. They've come in, they're talking to you, they're probably laughing at you, but you're worried, do I need to scan this child or not? So if a child is less than 2 years of age, if it's GCS 15, palpable skull fractures, altered mental status, okay? So agitation, somnolence, low response, repetitive questions. If they have any of this, then you need to CT the child, okay? If they're not GCS 15, they are palpable skull fractures, they have altered mentation, then they need to CT the child. If there's none of this, Then you're looking for, is there any scalp hematoma? So excluding the frontal hematoma. Was there a loss of consciousness more than 5 seconds? Is the child not acting normally as per the parent? And then, of course, was there a severe mechanism of injury? Either a fall more than 3 feet, motor vehicle accident with ejection, rollover, or someone died, or if it's a bike or pedestrian and was hit by a vehicle and they did not have a helmet if they're riding a bike, then that's a significant severe mechanism of injury. Again, if they were struck by a high impact object, like someone threw something really heavy into their head. So if they have any of this, if the answer is yes, you can weigh the risk. Either admit them for observation or do a CT, okay? You decide. So when say shared decision making is you and the parent decide, does the parent want to take the child home to observe the child, or does the parent want the patient admitted for observation? If they're going home, then they should be able to come back quickly to the department if they need to come back quickly. Or again, if they're being admitted, then they need to be observed, okay? So, but it's a decision. So this is a situation where you can actually bypass the CT, but it's a decision you'll have to make with the parent on this. So some of the things that you can consider, again, if it's multiple versus isolated factors, worsening findings during observation. If the things are getting worse, then probably you want to do a CT. Your clinical judgment accounts for this. So if you've seen similar incidences, make a decision. Again, parental preference. Do you want the CT or not? Remember, the key thing behind these decision rules is we do not want to CT every child who fell and hit their head. They fall all the time, okay? So we can't keep CTing them. Again, this increases the radiation risk. And yes, the risk may be minimal in terms of development of cancer, but it's there. It's not a non-existent risk. Okay, so have this discussion with the parent and decide which works best. But again, if your parent has no good safety net in terms of being able to come back, then definitely you may want to keep them and observe them from the hospital. And again, if your child has know these symptoms, then a CT is not indicated. Send them home and have a nice, good, mild head injury discharge advice for the parent. As you can see, the risks. So risk is 4.4 of clinically important, 4.4% even in this population. In this intermediate population, risk is less than 1%. This is less than 0.02%. So again, feel comfortable if you've gone through the algorithm and you'll be able to actually say your risk is less than 1%. So happy to send you home, as long as I'm sure you'll be able to come back if you need to. If your child is 2 years and older, again, similar things, okay? GCS, size of basal cell fracture, altermentation, and if he has training, get a CT. Again, 4.3% risk of brain injury. If there's if there's vomiting, loss of consciousness, severe headache, severe mechanisms, as is said, or similar to the other one, if there's yes to any, again, similar discussion, observation versus shared decision making. CT, again, 0.8% is the risk of injury. So this means essentially if I send you home, there's still a 0.8% chance I may have missed something, okay? So again, something you have to discuss with the parent. And again, if you're observing the child, this is much less than a 0.05% risk. Again, so not every child needs CTs. There's very good CT head rules from the PICAN, the Paediatric Emergency Care and Research Network. They do a lot of good research, especially around trauma and kids. All right. So burns, if it's less than 10%, okay, so have this chart, work it out. If it's less than 10%, they can get oral fluid resuscitation. If it's more than 15 to 20%, IV or IO fluid resuscitation is required. Again, we use Parkland's formula, which is 3 to 4 mL per kg per hour, half in the first 8 hours, the rest in 16 hours. Work on the 3 mL per kg, okay, start with that, see how that's going. If you're having adequate urine output, which is your 1 mL per kg per hour, you're doing good. If it's less than that, you may give 30 to 40% more fluid in the next hour and see whether that improves the situation. If there are other things to worry about, suspected head inhalation or injury, electrical injury, other traumatic injuries, then of course you want to go the higher 4 mL per kg. Again, maintenance fluid, maintenance fluid, maintenance fluid. So there's resuscitation, and then there's maintenance fluid. All right, when do you send these people to a burn center? So not all burns will have a major burn center. I think Kenyatta, MTRH, may have one. All burns in a child less than 1 year, burns in a child 1 to 2 years of age, with burns more than 5% of total body surface area. Patients in age group with 3rd-degree burns, patients older than 2 years with partial thickness burns greater than 10% total body surface area. Patients with burns or special areas, hands, feet, genitalia, face, perineum, major joints, electrical and lightning burns, chemical burns, inhalational injury, circumferential burns, kids, so it's less rare that kids have pre-existing medical conditions, but they have them, they definitely need to be admitted. Again, burns and concomitant trauma, pediatric burn cases where child abuse is suspected, all this needs to go to a burn center. Again, burn patients with treatment requirements exceeding the capabilities of where you are, then they need to go to a burn center. And of course, if the wounds become infected, then they need to end up in a burn center. So this is good criteria to know. So most of them can be managed, and I'm sure you're managing them in your EDs, but always worry about that child who needs to go to a major burn center.